Multidisciplinary teams, or MDTs, are what we need in healthcare, but making them actually work in practice across hospitals, community and aged care is easier said than done. There's growing interest to fund MDTs more broadly, so it's a good time to look at what helps and what gets in the way. In this special episode of Talking HealthTech, thanks to THT Plus company partners Infomedix, we're doing this one live online to speak with industry experts on how to build and sustain collaborative care models that are clinically effective, patient-centred and future-ready. I'm joined by Bettina McMahon, CEO of HealthDirect Australia, Elise Ford, Account Manager for Infomedix, and Dr. Sanka Amadoru, Geriatrician and Founding Director of ARIA Health. So prior to this session, we asked our audience, what's the biggest barrier to making multidisciplinary teams, or MDTs, work in healthcare? 8% said lack of clarity in team roles, 18% said poor communication, 69%, so the majority thought that it was due to siloed systems, data and technology, and only 6% thought it was due to limited funding. We'll go to the panel to find out what they think. Collaboration starts with a conversation, Team HealthTech. Let's make it happen. It sure does. How you going? My name is Peter Birch. We're here live in real time for an episode of the Talking HealthTech podcast. If you're watching this or listening to this on your favorite podcast or audio player, then you're catching it not live. But it's great to see you. I'm glad I could explain that for you. G'day, Peter Rady. He's here in the room. Dan, g'day. Valeska. George from... he's en route to Greece as well. Bernie's here. So a lot of familiar faces. Sarah O'Connor, not Sarah Connor, because that's from the Terminator. We also have, that's an in-joke in the THT Plus community. You're going to have to be a member to get what's going on there, or not. I am joined today. You're not here to for me just to tell bad dad jokes. G'day, Melissa. Great to see you as well. I have here in the virtual room with me, I've got my panelists for today. We'll bring them up on the right there. G'day, Bettina, Sanka, and Elise. Thanks so much for joining. Excellent. Good to see you. Hey, Divya as well. If you're here in the chat, let us know where you're joining from and what you're doing here. Maybe we're talking today around MDTs, and I'm going to go to each of the panelists to introduce themselves a little bit more, but would love to be guided by those who are attending live in the chat to help us shape the direction of the conversation that we have. So, Bettina, firstly, can you introduce yourself, set your scene a little bit, tell us who you are and what you do?
Hi, everybody. Thanks for joining over lunch for those based on the east coast of Australia. I'm Bettina McMahon. I've worked in digital health for about 15 years and in the public sector sort of more broadly. Currently the CEO of HealthDirect, and we're really interested in understanding what it is consumers need to know how to manage their care, know when to access the system, the health system, and we assist them to connect them to the right care at the right time.
Love it. Thank you. One person who is not joining on their lunch break is Sanka. G'day, mate. How are you going? Where are you joining from today?
Well, Peter, hello from Toronto. I am not in my hotel room in the middle of the day with the lights on. It is actually just gone 10 p.m. here. And hi, everyone, dialing in on your lunch breaks. I am a geriatrician. That's a specialist in the health problems that get more common as we become older. And my job is to help older people live at home for longer with better health and better quality of life. And where do I do that? I work in the public hospital sector at Austin Health in Melbourne. Some colleagues and I run a private practice called ARIA Health, really focused on clinics in the community and visiting older people in residential care. I'm also involved in dementia research and in digital health advisory work.
Excellent. Thank you. And also joined by Elise. Hello, Elise. How are you going?
Hi, Peter. Hi, everyone. Thanks for having me join today. My background is in health information management and in health informatics, and I've had a long career in healthcare organisations and recently moved to Infomedix. So I'm very enthusiastic about supporting those who deliver healthcare, and I get to do that at Infomedix and help design solutions with our customers to make that care delivery easier.
What a great all-star panel. And as George pointed out, it's worth getting up at 5 a.m. for him. Not that it's a competition, George, but that's okay. Let's focus on the content at hand. So it's great to have all the expertise in the chat and up on the stage here as well for this session. So I might go to you, Bettina, to help us unpack this topic that we've brought people together today to discuss around building high impact multidisciplinary teams in healthcare. Because look, I guess we're seeing a lot of chronic and complex conditions in the community. They need ongoing coordinated input. From your perspective, what defines a high impact or a high performing team, a multidisciplinary team today? And how do we actually make that work, not just for the people in the team, but say for the consumers, the patients?
So multidisciplinary teams in healthcare are not a new thing. They have been operating for some time. So I'm going to approach that question with an eye on the future. So in the future, as you mentioned, we're anticipating more Australians are going to be presenting to us with underlying chronic conditions. Some of those will be managed and some of them won't be managed well. Some of them will be acute episodes and some will be sort of just at the beginning of that journey. So that, I think, is the direction of travel of the health of the Australian population. And so we need to think about how we respond as a system to that. So looking at what are the features of multidisciplinary teams that are high performing that will then meet those future needs. I think, starting with consumer expectations, that consumers today and in the future will not want their care managed in silos. So they're not going to want, the cardiovascular issues managed by a cardiologist and their diabetes managed by a combination of podiatry and vascular, so other sorts of professions, and a GP kind of doing their bits and pieces. They will be expecting to, be playing a central role, because for chronic, we actually do need consumers to be taking actions every day to manage those conditions. And we'll be increasingly having data, wearables, and other sorts of coaching services and preventive measures to assist them doing that. So they will be expecting for their care team around them, to understand that the consumer themselves have a program that they may or may not be following. And they'll be expecting the care providers around them to be supporting them in that journey in a holistic sense. So if we think about that, I was really interested to see in the survey before that 68% of people who completed that were saying that they thought that data silos were one of the inhibitors. I think it's broader than that. It's professional silos. It's the way that we've chunked up the health system, and then the data just kind of falls in around that. So I think the challenge actually is looking at how do we kind of think about the team. It's not just fixing the system, and really interested in Elise and her views of how systems can back in teams, but it has to start with reform and thinking differently about it. So consumer at the centre, understanding that they're part of a team and respecting others in the team. I think, we've got some mixed history about respect across professions. I think that's improving. I think, the leadership I see in place today in the colleges do actually generally have a respect for others in the profession. Occasionally we kind of see a beef in the media about that. So having that respect and that teamwork, proper collaboration that's around a consumer, and then of course having that underpinned by systems that reduce unwarranted variation and support data interoperability.
Yeah, and look, I mean, we'll come back to some of that too, and it ties in. But having Elise here as well on the technology side, you touched on a few kind of important roles, Bettina, that some technology can play, because it's easy for us to we can create a structure for the people and for the human to be able to receive care amongst different modalities, but they're going to get stuck. There'll be different responsibilities. Sometimes everyone will be looking to someone else to be solving, and no one's kind of owning the thing, if you know what I mean. And I feel like that applies to not just MDTs, but a lot of bigger projects. But everyone's health or a consumer's health can sometimes be a project in itself. I'd love to hear from you, Elise, on where you see the role of technologies helping smooth out some of those challenges around people getting stuck, or those lack of clarity around defined roles and responsibilities.
Yeah, I think one of the challenges around that is the ambiguity around that ownership, as you said, and there's that lack of visibility across those different disciplines in terms of having that shared view of where the patient's at, and so really from that technology perspective, we can look at making sure that we are supporting that collaborative approach and providing that transparency and visibility of where everyone's at for that patient's care journey.
Yeah. And I think about it from a clinician's point of view, Sanka, and I guess in your experience working across hospital and community aged care settings, there's different environments that a clinician might be in. And then I guess you're coming in at different stages for a patient, I guess, into a multidisciplinary team as well. I'd love to get your take, because is it a process of, I guess if I was outside of healthcare, I'd be inducted into a new project, or I'd get a kind of, not a handover, but at least here's some information for me to be able to get across, the project or the thing that I'm trying to address. What's your approach to bringing, I guess, a new clinician into, say, an MDT, when we think about, it's not just this is how you use the tool, but it's almost like a mindset thing as well, right?
Yeah, very much, Peter. I think you've hit the nail on the head. It is very much about mindset, and it is very much about goals. I've worked across my career with multidisciplinary teams in many different settings. So, as you say, from acute to community, in the hospital, out in clinics, and in the community, in people's homes and residential care as well. And the common thing is, well, what does the patient, what does the older person or whoever need? What do they want? Is that achievable? So really setting the goals is the important thing. And then for someone coming into a multidisciplinary team, there's probably three key areas that I'd say are really important in order to help patients or people be able to achieve those goals, which ultimately are our goals as the treating team, right? And those three things are: you need to have the relevant skills and experience, you need to have a degree of pragmatism and flexibility, particularly in our specialty area, dealing with older people who have complex and chronic needs. And I mean, last but certainly not least, communication is a huge one. The ability to communicate well with patients, with families, with the rest of the team, and outside of the immediate, we'll call it a silo, but outside of the silo, and to be able to communicate with other people who are involved in care or supplementing care. In terms of the skills and experience, the first thing I mentioned, I mean, there's so many different multidisciplinary team members or professions. So, that might be in my line of work, it'd be medical, nursing, occupational therapy, dietitians, speech pathologists, the list goes on. And if we're supporting someone, we need to have the right mix of people to actually do the job at hand. So if it's rehabilitation, we can have all of the above, but if we don't do a physiotherapist, we're probably not going to be able to do rehabilitation. And it needs to be a physiotherapist who's able to actually do what the patient needs. So if it's an inner ear problem, it's no good having a physio who's really good at knees, for example. So you need the right mix of skills and experience. And scope and role clarity is really important as well, because a physiotherapist, again, for example, may be able to do a wide range of things, but we just need to be able to focus perhaps on the inner ear for this particular patient or this particular team's goals. The pragmatism and flexibility is very much about, particularly in the community, making sure that we're not trying to do things by the book, because patients don't read the books always, and particularly when you get out of clinical environments, which is where care needs to head. We need to head into the community more and more. It's not going to be cut and dried. It's never going to be perfect. It just needs to be good enough. And to be able to have the practical flexibility and the mental flexibility to be able to do that is really important, and it comes down to attitude. And I think as a through line through all these things, the skills, the pragmatism, and the ability to communicate well and effectively is digital. And increasingly, digital literacy is becoming a core skill set that is required for any clinician joining a multidisciplinary team. I'll give you the example of Better at Home program. So this is the clinicians I mentioned before, trying to get people either home earlier from hospital by offering rehabilitation services in the home, or trying to avoid a hospital admission altogether by offering them the rehabilitation for carefully selected people at home, and not waiting until they get bad enough that they need to come to hospital. So this needs the ability to do daily quick check-ins over video conference, because people are in different bits of the hospital or potentially out on the road. There needs to be asynchronous communication for referrals or troubleshooting. There needs to be the ability to check in with video or sometimes phone with the patient directly, or if you're at someone's house, if you're at a patient's house, to be able to get in a colleague's opinion with you supporting the call to be able to get the right decision in a timely way. And there's lots more coming. Ambient scribes in the public hospital system is happening in some places, not in others, certainly happening in private land. Other AI case selection, clinical decision support, these things are all things that are going to be just part of daily work, and digital literacy and the ability and willingness to learn are going to be core things that are going to be needed.
I think about some of those things that you mentioned, which all sound super practical, and the things that we need. Interestingly, like a lot of the technologies, they all exist today. It's not like you couldn't, like, yes, of course we could do a virtual consult or an AI scribe, or the and everything is available online, but it's not as simple as just giving clinicians more tools, because that's I guess the problem that we're in now, right? Is that there's all this disparate, like, it needs to be secure and have access to the right information, and there needs to be consistent. And once you're using this particular tool, you need to be able to access the information afterwards. So it's, yes, a technology challenge, but a lot more than that too. Do you think?
Yeah, I think it's never about the technology. It's always about the people, and then how the technology fits into the way they're going to use it to, again, achieve the goal they're trying to get to, and how it fits into the workflow. And often a lot of things in terms of tech solutions will fall by the wayside if it's annoying, basically, if it's too annoying to get over the initial learning curve and implement into a day, or if it just doesn't work when you need it to.
Yeah.
Which is why for example, we see phone being reverted to much more if there are issues with the laptop or the tablet or a poor Wi-Fi connection when someone's out on the road.
Yeah. And if I was to build on that, Bettina, then I guess taking into consideration all of these factors or unique features of the environment that we're in right now, we talk often about the pressures on workforce. There's a lot of interesting advancing technologies. I love that there's a whole side chat happening at the moment that you're managing as well, which we'll come to in a moment, around other technologies, beneficial for those that have attended live. But also there's policy that plays a part, which you kind of touched on at the start too. So does that give us like an opportunity to step back a little bit around when we're looking at MDTs? How do we, like, are we even doing this right? Do we need to rethink them? Or what's your kind of take? Because I know you think a bit picture on this as well.
Yeah, we're thinking about this. So for HealthDirect, at the moment, we have a digital channel and a phone channel, and the two kind of sort of, they flick between them. So if you ring us, you can kind of speak to a nurse, you get a triage assessment and healthcare advice, and then we'll send a text message with a link to that self-care advice to manage your symptoms while you're waiting for care or to sort of ongoing. And the same with the digital channel. If you go through that and we think you would benefit from speaking to a nurse, then we say ring us. So there's kind of that. Whereas we're thinking about, there's only a certain number of nurses in the country, and we've seen the predictions of 70,000 short by, in 5 years' time. And so we're thinking about, what's our contribution? Are we a drag on the system, or are we supporting that? So we've been thinking quite a lot about workforce futures. And of course, the Commonwealth put out a report last year, led by Mark Cormack, about that too. So we're kind of thinking, what within our own four walls, how can we have digital do much more heavy lifting? So how can we have a conversational agent, like a non-human agent, do a triage survey, for example, ask the questions and answers before it's time for a clinical decision to be made, when it might be then handed over to a human. So we're kind of thinking about what's just in our own system, what is the combination of it's AI, but other digital technology along with humans to actually optimize the use so that we're actually using our precious human resources where we really need the most. So if I kind of take that idea and then extrapolate that out into a multidisciplinary team, what is the option for technology and AI in particular to play a role in a multidisciplinary team? And how do we see it as a participant in that, rather than just there's a tech bit and then it's all the tech does is it helps the humans communicate? I actually think we'll move beyond that and we'll be saying, well, what is the role? And in your pie graph earlier, Pete, there was a role for roles and responsibilities and who's doing what. Well, what's the role and responsibility of tech? Are we all clear on that? Is it safe? Do people trust it? Really interesting report that came out last week from the TGA about where they think they're at, and then they've signaled that they want to keep the conversation going. So what's the role for tech? What's the role for clinicians? What's the role for consumers? I think we're going to have to really rethink that, because we just won't have enough people to keep doing what we're doing today in the same way. It's also not working. We're not, I think for the investment we're putting in, public, private sector and consumers, I don't feel we're getting the health outcomes that we would expect from that investment. So how do we bring more productivity and performance, get more, squeeze from the lemon in that sense. So for me, it's thinking about how do we rethink the role of tech, rethink the role of workforce? Where do we want people involved? Where does it really matter? And for Sanko's sort of experience with geriatric patients, but older Australians, they'll have a particular need and expectation. Younger Australians will have a particular need. People with chronic and complex conditions, they'll also be wanting to, we're already seeing this, they want to engage much more with their own communities. Who are other patients experiencing what they're experiencing? My own daughter has a speech disorder, and so she's got a kind of teen group that she connects with. Yeah, we see a speech pathologist and we've got some kind of treatment we apply at home and that manages it. But for her, kind of at that age group, connecting with others who are having comparable conditions that they're managing is really helpful for her. So how does all of that come together? So I think the communication, and we've sort of raised this, and someone else put in the chat, communication is super important, but we've got to move beyond that mindset of it's not just communication amongst the clinicians in the multidisciplinary team, it's what's the broader network that needs to support a consumer to have agency over their health conditions and to support them holistically from mental health, social support, health care treatment, and in particular for chronic disease and lifelong conditions. It's different to an acute episode.
Yeah. 100%, and that sentiment is definitely coming through in the chat. We can see there too. Sorry, Sanka, I thought I saw you come off mute. Then did you have anything to add there, or that was just a strategic placement? No, all good.
Someone, if I can say, someone's mentioned in the chat about the role of training. Really interested to, what is it about education? It's easy for us to say, universities just have to fix this. I think that's a part of it, but it is a kind of mindset. And where does that work best? I know a number of people on this, on the call and in the chat, they're involved in curriculum design. They're involved in delivery of either ongoing training and professional development or that first part. I think that's a really important part as well.
Yeah. 100%. I can see all that coming through here. I actually want to, and I'll come back to some of those points in a moment. I encourage everyone who's attending live to continue to put those comments and questions in the chat, because that'll help us round out the conversation further. What I did want to do though is, Elise, thinking about, what we're doing today. I'd love to, and I learned by hearing about real world examples, and as those familiar with the podcast would know, where have you seen it done well, where I guess the right technology and the right workflow has helped a team collaborate more effectively in healthcare?
Yeah, happy to share my experience with that, Pete. With the MDTs and my experience particularly around the MDT meeting, it's about that common goal of bringing those experts together to be able to make the best decisions for the patient and being able to support that. And so with the Clinivid co-design that we did, we had a really collaborative approach with the healthcare team. So there were many iterations going back to them, showcasing the technology to make sure that it really fit in with their clinical practice and that we weren't trying to actually change the way that they were doing their work. So first and foremost, I think having a flexible system that really helps to guide their workflow but doesn't dictate it, and supports them in their individual ways of working. We found that there was a lot of administrative burden around those MDTs, and it was someone's job to go backwards and forth trying to get information. There was lots of duplication of effort and very much lots of manual processes. And so we set about trying to really reduce that admin burden that was often on one person. The other thing around the MDT was about the structure of information, and there was lack of clarity, there was lack of structure, and so not having adequate information really was detrimental to having that high performing MDT team. And so we looked at how we could provide better structure, but making sure that that structure worked with the individual needs of those different teams. And so it wasn't a one sort of structure that fit everyone. And ultimately, we wanted to be able to improve accessibility. And so, it's important that you can have that sort of asynchronous approach and not have to have everyone particularly in the room to have that discussion, that you can start that discussion a long time before the actual meeting occurs, and that you have that platform that is available to all disciplines, and putting the patient at the centre and really being able to collaborate, to ask questions, to put information in, and so that when people are coming together, they really have that overall picture and visibility of where that patient is in their care journey. And so, the main goal was to really have that system in place that really strengthened that collaboration amongst the different disciplines.
And Sanka, thinking about real examples, you touched on the better at home model. I know we've talked about it a bit on and offline, so you might have to remind me how much we've covered in this live session, and for those I'm totally unfamiliar with it, but there's examples of it done well there, but surely there's gaps as well that can be kind of unpacked there too.
Yeah, that's right. So I think the better at home model is something that's a couple of years old in Australia, or in Victoria at any rate, and it's being done in a way that's not entirely standardized, and there's good things about that, and of course not so good things about that as well. But it seems to, at least anecdotally from my experience, seems to be really effective and gets a lot of satisfaction from a lot of people involved. I guess contrasting that with some of the work I've done in residential aged care, in non-acute settings, and I'll give you an example. So I was seeing an older lady, so she's in her early 80s, she's living with dementia, and she's got really significant arthritis in both her knees. She is not a good candidate for an operation because it would probably do more harm than good, but she lives every day in really significant pain, and this is painful enough in terms of her walking that she can only really walk very short distances around her room, maybe needs a bit of a wheelchair run up to the meals area in the nursing home. But the issue now is that the pain is getting worse, and it's now stopping her getting in and out of the car for her weekly coffee with her family, who will visit a couple of times a week, but they go out for coffee on the weekend. So she can't do that anymore, and that is one of the things that really contributes to a quality of life. So the GP refers to me with several questions, but one of the main things, the headline here is, can you help me manage this older woman's pain medication? Because we've got a clear goal. We want her to be able to get in and out of the car and get to coffee with the family. So I see her, I make some suggestions. There are some medication changes with the pain relief, and these are stronger painkillers. If we underdo it, she's not going to be able to do what she wants. If we overdo it, she might get drowsy and fall over and break a hip, and no one wants that, of course. So some close input is required. The GP is asking me for more help. This lady happens to be half an hour away on a good day on Melbourne's roads, so I decided to do a video consult. And then I case conference with the GP. So the GP and the nurse at the facility are there, and that can just be a phone call. And I do that a couple of times afterwards just to make sure that I'm supporting them in the management. The other core bits of this, I guess what I'd like to point out here is that I haven't got a team around me, and I'm practicing privately. I haven't got, apart from other clinical specialists, other geriatricians, we haven't really got physiotherapists, we haven't really got occupational therapists, and I can see some comments in the chat about how that's reimbursed in the private system, right, and the limitations there. So in order to get a physiotherapist or an occupational therapist to help this lady get a little bit better, to rehabilitate her for this very specific goal, we need to ask the facility to refer out to their contracted providers. And this is where this starts getting very silent. So this is an example of, I'll go back a step. So I asked the nursing staff to make the referral. They will refer to someone who is an external organization. They'll send a physiotherapist and perhaps an occupational therapist. Maybe the family need to find one themselves. And you're really flying a little bit blind here because you're not sure if the person you're going to get has the skills or expertise necessarily. Hopefully they do. It's very difficult to be able to directly communicate with them because they need to go filtering through the clinical information system or the notes in the facility or paper, if they're still on paper, to find the stuff and to kind of give feedback back to me or back to the GP. The same problem exists. It gets buried in the daily flow of notes, and it's very easily missed. And that's where gaps happen. The physio might turn up and work on something else and hasn't actually answered the question or helped the lady with the problem that she has. So these are the challenges when a multidisciplinary team is not as integrated and where the communication is not as integrated, and it's potentially very inefficient. Can still work sometimes, but not all the time. And I think this is something that we really need to get better at. There are some residential aged care providers who are starting to bring some of this in-house. So they're bringing the GPs and they're bringing the allied health practitioners in-house. And there is some signal that this is starting to both improve outcomes and be more cost-effective for the providers, because people are staying well for longer and they're not needing as many trips out or as many reactions to deteriorations that would have otherwise be preventable, and presumably more coffees for people living in the facilities with their families.
Interesting. I feel like that's really kind of a good specific example of the challenges that are faced and the landscape ahead. I'm looking at the questions and comments and suggestions too that are coming in the chat. But I also want to open it up to anyone else that's got questions here. I can see questions that came through prior to the session as well. I would have liked to have I could have put it on a neat thing, but the consistent theme that came across was, thank you, Dan, for submitting some questions prior, and Sarah, who I know are both attending live, and around where we see the ball going. A lot of AI questions, can I just say, that came through generally, and that's a consistent theme that's coming through in the chat as well. And actually quite a few people asking about how AI is being used right now in be it collaborative care models or MDTs or even any examples on how we might see these types of things being utilized. Even I saw a question come through this morning, I think it was from Alan, who asked about, can we use AI agents that are connected to My Health Record or a trusted health source like HealthDirect Australia to support patients through continuity of care and all these kind of things. So cool opportunity, absolutely. And I'm all for the let's see what new tech we can plug in to help assist this. Love to get the first hot takes from the panelists too on, should we be prioritizing utilizing AI to assist with some of these challenges, or should we be addressing these challenges in other ways, or should we just keep doing it because it's good research, but not really sure it's actually addressing these issues? Bettina, have you got any first initial thoughts?
Yeah. I've got a comment and maybe a question back, because I've found the chat really interesting. So in terms of the tech, so we are talking to the Digital Health Agency and the Commonwealth about, okay, well, how do we make use of the National Digital Health Infrastructure? We have an awesome healthcare identifier service, which provides a great fundamental building block to be able to accurately identify patients, which is one of the sort of challenges you've got with some of the layers of AI and other things on top. We've got the My Health record, which now we've got share by default legislation. Even more data will go into that, in particular path results and diagnostics in a structured way, using terminology like SNOMED, which will reduce some of the challenges around data quality. So I feel like we've got kind of all the pieces in place. And so we're thinking about, well, how do you thoughtfully explore in a 3-year type time horizon about how we might be able to use some of these tools to bring together care in a way that we have never been able to do before. So, it's early days, but certainly, we've seen the government's having a roundtable in August around how do we rethink productivity in the economy and what changes do we need to make. And I guess the question back to the panel would be, I noticed that Melissa said earlier, to have this to work, the tech needs to fit the workflow. And I agree with that. And like in 2015, there was a report, I don't know, it's probably just policy wonks like me. There was a report of the incoming government at that point, the Commonwealth level, and it's called Learning from Failure. And they commissioned a report. Peter Shergold had a look at 3, really big reform areas which hadn't delivered the benefits that were expected, and in fact had created harm. One of them was the pink bat stuff. I don't know if people remember that. So those sort of big programs, not just technology. And some of their findings were that the problem is once you have a grand idea, but then when you move into execution, particularly at a national scale, you have to chunk it down. And the way that we chunk it down often is we look at, what's the project, what do you need to time, cost, quality, you deliver on that. And then you sort of lose sight of the benefits measurement and the messiness of how you implement this in a healthcare environment. Elise talked about that. She talked about the challenges of actually you're trying to do this and then just someone has to do some extra admin work. And so that's, going to really derail what you're trying to do. Sanka's talked about, but you've got a patient who you might have a plan of how you get them mobile, but if they can't, then how does that kind of fit your cookie cutter approach if you're taking a program view? And then George has talked about, in the chat, Margellis about, but ultimately what gets paid gets done. And so if you don't, verbally you hear George, if you haven't kind of thought about the payment methods, then that'll derail. So kind of thinking about that report, which looked at, how do you learn from experience? How do you evaluate? That report said fragmented evaluation was the problem. It just kind of evaluated little silos. So thinking about all of that is really interesting. So Melissa, says the tech has to fit the workflow, but then there's an alternate view in the chat that Nathan's put up saying that it's actually not about AI automating processes. We're missing a beat if we're kind of looking at that, and that's what we're focusing on at the moment. Instead, we need to rethink how does AI and tech in sort of more generally augment care, and how do we think about it differently, and how do we measure that differently? So starting with, the future of where we want to move to, and then redesigning. And I don't know what the answer is, because it's easy for me to say, oh yeah, just redesign and, do it for the patient at the center. But how do you deliver that? And then how do you get the benefits that we all need, rather than reducing it down into project components, which we're all really good at? How does that interface with the messiness of the health system? So a bit of a brain dump, and over to the brains trust on the panel of Elise and Sanka, who have much more experience than me in actually hitting the health system and trying to implement this stuff at a real level.
I love that. I don't know if a clean, succinct answer, but this is not the forum for clean, succinct answers. This is where we would go rogue and riff on it until the stream stops. And
why not? If not over lunch or 10 p.m. in Toronto or 5 a.m. in where
this is what we're here for. I love it. Sanka, any first thoughts?
Look, I mean, Messi is right, and I think I kind of tell my juniors semi-jokingly that going out and doing community medicine, so home visits, is kind of like jungle medicine. Like, you don't know what you're in for, and it's just going to throw everything at you. Look, Bettina, lots of great points there. I think one of the first things I'll say is that before talking about agentic AI and wide sweeping system changes, that what clinicians really want is to be able to access information, and like not reams and reams and reams or gigabytes of data. They just want relevant questions answered in a timely way. So how do you do that? You need to be able to connect systems so that that information is available and searchable and findable. And the flip side of that is that you also need to not overly add to the admin burden. And if anything, you need to be able to save time in terms of not duplicating, for example, me writing notes in a hospital system and then having to write it in the nursing home note system as well, and then somehow figuring how to get it to the GP clinic because that isn't connected. So just working, I guess, from a clinician's perspective, if you fix a connectivity problem between information sharing and save some of the admin time so that we can actually spend more time doing what we went to university for, which is seeing patients, that'd be an amazing win. And fine, I mean, if AI starts to fit into that, then that's okay. My main comment about agentic AI is that it always will need a human in the loop, as the saying goes. Healthcare is messy. Healthcare is not like other industries. I'm sure everyone on the call appreciates that. But anyone out there in cyber time and space who's listening to this, if you're kind of coming into this expecting this to work like logistics or expecting this to work like finance, it's not going to. As we said, it's the jungle in a lot of ways, and having a human in the loop is really, really important. And recently, I've been thinking that perhaps because fundamentally AI makes mistakes that are kind of unprecedented. I know that word gets thrown around a lot, but it makes mistakes that humans wouldn't make. So when we're looking for mistakes, we have been trained over our lifetimes and, generationally as a species, we're trained to look for mistakes that other people make. So how do you recognize a mistake that a machine makes? And I do wonder if the way that we, from a clinical governance point of view, if the way we sort of check or double check the outputs and then the decisions that are made to hopefully get to a good outcome needs to involve potentially more than one person, or there's some other way or a different paradigm of checking the outputs that we perhaps haven't figured out yet, but time will tell. And the last comment I'll make is just this idea of asynchronous versus synchronous communication. I think, again, being able to find the right information from the person who was on night shift the night before is really important, and no one expects that person to wake up and contribute to the handover in the morning or in the afternoon. At the same time, there is a lot of value in direct conversation, and there's stuff that you just can't express, or it's difficult to express through the written language or written words, or typed words anyway. So, I mean, I think there's a place for video, and that's being really, not as in video consultation, but video recordings. So if someone says, hey, has this person got Parkinson's-like side effects from a medication, a video will be much more helpful than someone trying to describe what the shaking looks like over a phone call. Or even if it's a video consult, I can't tell if someone's muscle tone, how stiff their wrists are. I can't tell by looking at them. Right. So there is a place for synchronous communication. There's also a place for in person. And this may be controversial coming onto a health tech podcast and saying video consults are not everything, but there is a place for support people, and there's going to be a place for clinicians and support clinicians as well. That's not going to go away. That's the ideal. If you can't do ideal, do you do nothing at all? I don't think so. But that's my brain counter, Bettina.
I've got my own 2 cents on that too, but I'd love to get Elise's any additional takes that you have on the current flow.
Yeah, so just to Sarah's point about, techniques to fit the workflow, and, from the experience with, the Dakota sign with Clinivid, we found that some of the workflows, were not ideal. And there was, that extra burden on certain people in that care team, and, less burden on others. And so whilst, we do want to fit the workflow to, the clinical practice, it was also about improving that workflow at the same time, and making sure, where there were burdens, and, where there were challenges, it was really about addressing that with Clinivid, and being able to improve the workflow. So not just mimicking what's in place, because we don't want to have those same burdens. It was really about, improving that workflow.
I'm going to go on a tangent for a moment, but it's relevant because I share my own experiences within the healthcare system as much as I can, but sometimes, you only want to share so much. But let me share a pivot story of, so I took my cat, Johnson, the 15-year-old ragdoll, to the vet this week, and he's got a few complicated things, and probably a multidisciplinary team now going on as well, and carers. The usefulness of technology in the console, as in the video that was taken of his current state within a home environment versus the, what he's physically doing within a consultation at that point, I think, well, hey, that was super handy that I've got my phone. And it reminded me that in other consults with human fur babies, often what I'm going to is, it's almost like we've, as consumers, we've plugged the gaps that a lot of these system that exist in these systems, because there's no ability for me to easily load up in real time an asynchronous video of the cat making, cat things. But in a human context, it's like, it's just easy for me to capture it on my phone, and then I'm standing there in the consultation like this. But the amount of, like, I've taken photos of, my kid's X-ray while I'm there in a consult, because it's just easier for me to take it on the screen. And sure, it's not the best, but that means I can share it with somebody else. And is it secure? No. But from a consumer, it's super accessible. So do we have enough in place now for us to plug those gaps? Evidently not, because we're all looking for the solutions for the system to just work like that. But as soon as, if the vet told me, well, just download this app and then put, two-factor authenticate this, I'm going to be like, I'm just going to film it on my phone, because I don't have the time while I'm trying to chuck it in a carrier. So we're not talking about vet medicine here, but we can think of all different examples of real patient care that. So my thought sometimes goes to, is the system broken enough? I don't want it to be broken more, but are we trying to optimize for even better? Because we're in a pretty good healthcare system right now. I'm not sure that's the right answer, but I guess that's my provocative back to. And sometimes it feels like we don't see huge transformational change, because maybe we don't need to transform. Like, we're not so dramatically broken that there needs to be that transformation. So again, I don't have a purpose for that particular statement, just a thought piece that exists because Bettina got me in the mood for pontificating. But open to any other additional comments from the panel on that one too.
I mean, I'll sort of jump in briefly. So I was having a cup of coffee this morning with Carlo Bellini. If anyone knows Carlo, he's a kind of future thinker, and every time I meet with him, he leaves me kind of reeling, thinking I think outside the box. I'm clearly not, after I catch up with Carlo. Anyway, he was saying, look, there's kind of these two things going on in healthcare. One is compliance. We need to be compliant with protocols. There's regulation for good reason. But then also looking at where we're at, we need to have courage. And he was saying they just rub up against each other. And so how do you kind of manage that? And to what you're saying, Pete, about, I know it was your cat, but we hear from consumers, all the time, that there are certain consumers who are being underserved by the health system. I don't think the health system is broken. I think it performs remarkably well for the Australian population. If you look at internationally where we're at in terms of health outcomes of the dollars that we put in, we actually have good health outcomes for many Australians. Now, we don't. There's certain parts of the communities, Aboriginal Torres Strait Islanders, people from non-English speaking backgrounds and disadvantaged, absolutely, there's more work we need to do. But within that, and sort of thinking through what Carlo was saying, what we're hearing from consumers is, for those who are being underserved, they're often turning to things like ChatGPT. Many of you would have heard this. They're putting their diagnostic results straight in there. They're putting there's like, have all of this because I'm sick and I haven't got a diagnosis, and so I haven't got a treatment. And that's a problem for me in my life. And so they're kind of, throwing caution to the wind. I don't know where this stuff is processed. I don't know what model it's training, but frankly, I need a service. And the promise of things like just even ChatGPT is delivering for many consumers I've spoken to. They're saying, I got some hints. I got some ideas that I could then discuss with my GP. The GP then ordered some diagnostics, and I ended up with a plan, and my life is getting better. So if we're dealing with that right now today, in a way that, Pete, you said you took a picture because it's better than nothing, and it's not, is it skew or no? And is it, God knows where the data is stored, but people are kind of like, well, I'm in a point where the value proposition and the promise is worth it. And that's what I need, frankly. Now, what we're thinking about is, well, how can we provide that promise in a way that they don't have to compromise on privacy or security or data sovereignty? What might the role of government be? These are the sorts of things the TGA is thinking about. Where do we put guardrails in place that also doesn't kind of lock us out of the benefits that we can get from some of these tools? And I know there's been a lot of talk about it. It's not just AI. It's actually technology more broadly. I think 90% of it is just general tech, like good use of technology, but AI is the kind of icing on the top that realizes some of those benefits we've just been struggling to reach.
Yeah. Look, I can see as we start to wind out for the time we have available to us in this conversation, I might borrow some of the questions that and round them out into a kind of future-facing one for each of the panelists to help us lead out on. Because I saw Sarah, ask the question on registering, where do you see MDTs evolving over the next 5 years, and the role of all those emerging technologies and co-design in this space. But Dan also asked, McInerney asked a similar question around, what we've learnt already and what we can apply in our own approach today. So maybe in just taking that theme, thank you, Dan and Sarah and others for contributing in the chat, and also continue to keep those questions, comments going through if you're here. But I might go around the room, perhaps Elise to start, and then Sanka, and then Bettina for any other final thoughts or the direction or your hope or vision on where you see things going, or hope that people take away from this session today.
Yeah, for me, Pete, I think it's really, building technology for the way that our healthcare teams are working. So, that being across time, across disciplines, across organisations, and, that we're able to, put our technology into the reality of clinical practice.
Yep, love it. Thank you. Nicely said. Sanka?
My takeaway from this is that I don't think things are going to stay okay enough to not change for very much longer. I think the writing's on the wall. If we keep doing things the way we are, the health system and the aged care systems are not going to be able to cope in the coming decades, and we're not going to have the workforce to be able to support the needs of, fundamentally our older selves. So the need is certainly there, even if it seems like it's fairly calm now. And I think the issues of siloing and the issues of being able to connect and get the right decisions made at the right time, with changes to the way we work in multidisciplinary teams. So integration and an ability to kind of fit in a modular way where there isn't the local presence of those multidisciplinary clinicians are the ways forward.
Totally. And Bettina?
I'm really sort of buoyed by the commentary in the community through the chat, and Sanka and Elise, from sort of the vision of where we need to go. I feel like we need a firm eye on the future and to be thinking differently. And I've kind of seen a real sense of that. At the same time, that's not enough. And, too many times, I think, especially when you're talking about national scale rather than just a kind of local pilot type of a thing, just being pragmatic about what are the steps you need to take to get there. Sanka, I like the description of jungle medicine. It's just chaotic. And so, trying to apply fragmented evaluation doesn't work. Elise just saying, when you go to roll out, you can have a vision of how we're going to improve things, and, having that courage to improve workflow. But how do you do that? What sort of leadership and clinical leadership do you need, and not underestimating that? So I guess my takeout is you kind of have to do both. You have to have a firm eye on the future, know the direction of travel, but you need to be pragmatic about, you can't just kind of come in with an aspiration, as a team swooping in and saying, this is what we're going to do now with AI agents or whatever it is. It's going to be like, well, where are we now? And how do we manage this change in a way that is safe, that clinicians are supported and leading? But how do we also shake it up? Like for a clinician who's been working in a certain way for 20 years, we can't just expect them to reimagine the future. So what sort of leadership do people in this community need to offer to kind of bring together that vision? To say, well, this is where we need to head. And I feel like we've got the creativity to do that, but it will live or die on the pragmatic implementation skills, which I think we have, but we somehow have to find a way that we're moving that broader direction.
Love that. Look, I'm super grateful that I've had the opportunity to chat with you three amazing humans, and the wonderful contribution from those attending in the chat as well. It'll make for a great episode that'll be available in the coming weeks on the Talking HealthTech podcast. So until then, Bettina, Elise, Sanka, thank you so much for joining today.
Thanks, Pete.
Thanks for the opportunity.
Thanks, everyone.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.